Thank you. So we're here talking about integrative approaches to mental health, and I'm talking about pain. So it's a bit off topic, but I would guess that I'm preaching to the converted in that we know that the interaction between mental health and physical pain is very close. And so while I am talking about pain, those of you who've read a lot about how the brain works in depression or anxiety may recognize what I'm talking about in terms of what happens with pain. We're using very overlapping neural circuitry when we feel pain and when we feel sadness, fear, and worry. So they really do fit together very nicely. So first I'm going to talk a bit about chronic pain itself. So what is chronic pain? How do we conceptualize chronic pain versus acute pain, and when we study it and when we see it in the clinic? I'm going to talk about the brain and how the brain processes pain, how chronic pain may be different. I'm going to talk about both somatic and visceral pain conditions. I'm a gastroenterologist and I study visceral pain, so chronic abdominal pain, dyspepsia, irritable bowel syndrome, all gastrointestinal problems for which the real cardinal feature is not their gastrointestinal issues, but the sensation of pain. And I'm going to compare that to, as an example of somatic pain, chronic low back pain. And it turns out that the way we experience these in the brain is quite similar. And then I'm going to talk about mind-body therapies for both. I'm going to focus on the top-down therapies. So mind-body therapies certainly could go up, so body-mind therapies. I think that the more bottom-up interventions that are exercise-based, tai chi, yoga, things that start with the body, are really just as effective as those that go from the top down. So I'm going to talk today about hypnosis, about cognitive behavioral therapy, about mindfulness-based stress reduction, meditative therapy. But for the sake of time, I'm going to focus on the top down. So why is chronic pain so important? It's one of the big troublesome areas in our healthcare system today. A third of us will have some type of chronic pain episode in our lifetime. And at least half of us experience in the workforce some type of pain, whether it's headaches, whether it's back pain, whether it's stomach aches. All different types of pain will affect us and our families. Our current pharmacologic therapy is really not much better than it was 20 years ago or 50 years ago. We're using the same types of medication that we've been using for a very long time: aspirin, nonsteroidal anti-inflammatory medications, and opiate medications. We've added on some fancier things. We use antidepressants, we use anti-epileptics. We have some other interventions, but we really have not been able to make a big movement in improvement in chronic pain. And in terms of opiates, we have a situation in our country where we use the majority of the opiates used on this planet here in our country. So less than 5% of the population lives here, but we use 80% of the opiates. And so clearly there are other ways that we can manage pain that other people are using elsewhere. We don't have to necessarily go to the prescription pad. And I think that's one of the key messages of these types of approaches the integrative approaches for chronic pain. Despite the medicines that we do use, we usually are not successful. So at least half of people who are on pain medicines are not satisfied with the effects that they get. So we need something else. The traditional research, and really the big push over the last 20, 30 years, has been to try to understand, based on the transduction and transmission of pain, to understand what happens at the site of pain and what happens at the nerve and how is that pain sent up and how can we interfere with that pharmacologically. What we often forget with the traditional approach, though, is the affective component, the cognitive component, the motivational and memory component of pain, which in the setting of chronic pain is probably the most important. So we first have to say, well, what is pain when we start to talk about it? Often in research, we're thinking about nociception, the idea of sensing pain at a specific location. But what the International Association for the Study of Pain calls pain is an unpleasant sensory or emotional experience associated with actual or potential tissue damage. So pain is an experience that's complex. It's not nociception. And when we think about the anatomy of pain, we want to think about, yes, there may be a pain source in the periphery. And we're pretty good at trying to understand, particularly with animal models, the transduction and transmission of that pain through the dorsal horn, through the spinal tracts, up into the brain. But it's really what happens up a bit higher in our conscious perception, modulation of that pain, that leads us to the major problem we have with pain in this country. We know that even if this pain, the cause, this nociceptive cause disappears in the most dramatic sense in phantom limb, but really in many, many situations where pain starts from an injury, the injury seems to heal, and yet the pain stays there. We know that something is happening in the brain that allows the conscious perception of pain to persist when the actual injury can no longer be found. And when we're sitting in the room with a patient who has pain, this is sometimes a very difficult concept to get past when I have a patient who has pain and wants a surgery or wants a medication for that pain, to remove it, to stop it, to cure that problem. It's really important that they understand, and that we understand, that some or all, in some situations, of that pain is being generated not so much at a peripheral site, but in the brain. So what's the central circuitry of pain? We have our sensory areas, so the insula, the somatosensory cortex, where incoming pain comes. It tends to come in initially at a subconscious level, and then it interacts with a number of different areas in the brain. So we have in the sort of reddish-orange a network of brain regions that determines the salience, the importance of that pain. Do I need to let this come to consciousness, or can I suppress it? And is this a pain, a sign of something dangerous that I need to act on and make big changes? We then have the areas of cognitive modulation of that pain. What do I think about this pain? Does this pain remind me of something else? What do I want to do with this pain? Where we actually, our cognitions can affect the intensity of this pain. And then we have descending pain modulation pathways down the brainstem that can go back to that peripheral site and either turn the pain down. So in an acute situation, you're injured, you're in a car wreck, you have pain, it should hurt a lot, but you need to get out of this dangerous situation, and you don't feel the pain very much until you're at safety, you stop, you take a deep breath, and then all of a sudden, wow, you can really feel it, right? So when it works most effectively, the system turns off the pain when it's best for us and turns the pain back on when we need to know about it. Unfortunately, our cognitive modulatory circuitry and our emotional circuitry sometimes messes up this process. We turn the pain up when we could be turning it down. And because of the complexity of that experience of pain that we have, one of the traditional ways that we studied pain, which is in an animal model, turns out to be pretty flawed and has led us down a number of pharmaceutical pathways that have been very effective for treating pain in the animal models, but when brought into humans have been dismal failures. And that's because our brain is quite different. You can see here in blue, this is our prefrontal cortex. This is where we have major modulation of our pain. The primates, which we don't do many studies in experimentally, they have a prefrontal cortex. It's a bit smaller. The other place we control how we process pain is in this little area here called the insula, which is very prominent in humans, is seen in very few mammals, primates being one, whales being another, elephants, really not any other animals that we can study, the mouse doesn't have these regions. This is not the prefrontal cortex of the mouse. That's its olfactory cortex. So it's doing different things with its brain. It is not a great model for studying pain. So much of the basic science that's done has not helped us as much as we would like in terms of understanding pain. What it has helped is it's helped us understand some of the basic circuitry of the brain. One of the things that we've learned from it is how, for example, in the gut, how the neural circuitry goes from the gut through the brainstem up to the brain. But then what we have found in humans is that this modulation can actually change what seems to be a physiologic signal and reinterpret it into what is thought to be a disease signal. So in some cases, if you have someone who wakes up in the morning with a cognition, and I see this all the time in my patients with irritable bowel syndrome, what will my day be like today? Am I going to have pain? It'll work. Am I going to be able to function? Am I going to be able to socialize? That fear is there, and the memory of how pain has impacted that person is there. A peripheral stimulus can occur, and this could be the same with back pain. For those of you who've had back pain, you feel one twinge, and all of a sudden you've already gone to like, am I going to be able to drive? Am I going to be able to get to where I'm going? That symptom may be physiologic. It may be just a little rumbling in the belly. It's time to have a bowel movement. It's time to go have breakfast. But what the brain does with that is says, oh, wait a minute, I feel something. And that descending pain modulation, instead of turning it down, and most of us who don't have bowel symptoms, I rarely feel my internal sensations. It wouldn't ever come to consciousness. It's not important to me. But in someone with irritable bowel syndrome, where it's a salient signal, that gets turned up. And all of a sudden, a physiologic signal becomes a pain signal. So really where we want to look often is in the brain to understand how our patients are feeling pain. So what do we know about the brain in chronic low back pain? And surprisingly, there's a fair amount of research, but not nearly as much as one would hope. But what we do see is that when you have chronic low back pain, you have decreased gray matter in pain-related areas. The cingulate cortex, the prefrontal cortex in particular, the thalamus. So areas involved in sensation and modulation of pain. The overall gray matter loss in a patient with chronic low back pain can be equivalent to 10 to 20 years of aging. And this has been seen not only in gray matter, but also significant decreases in white matter. So, and this is probably not specific to low back pain. Pain impacts the gray matter and the function of the brain. When we look at the resting state of someone with chronic low back pain, what we see is in just a resting, mind-wandering task, they're just laying there, eyes closed, doing nothing in particular. Those areas that are associated with affect, emotion, are more connected to that network of resting than in someone without pain. And they actually look very similar to someone with anxiety. So there's a change in the way, even at rest, not undergoing any particular stimulus, the brain functions differently in back pain. We can look to the brain and see if there's something that makes someone develop chronic back pain. And that something is connectivity in this part of the brain, the prefrontal cortex with the nucleus accumbens. And this is part of what we call the salient circuitry, so an extension of how we determine what is important. And this really lovely study, what they did was they took people who had subacute back pain, so brand new back pain. I've had back pain before, once. I didn't like it. I'm hopeful that my response to it, which was never to have back pain again, had to do with the fact that I had poor connectivity in this particular region of the brain. Because what it turned out is the amount of connectivity you had in that salience region depended on whether you're going to be in this column, so persistent back pain. So at baseline, when you have subacute back pain, If you've got strong connectivity there, you're much more likely to develop persistent symptoms. Whereas if you had low connectivity, you would not. They also found that while the gray matter volume was similar in all of these people at baseline, these are just people who developed a back pain, those who had persistent back pain over 60 weeks of follow-up had a big drop in their gray matter. So this is not a predisposing fact that you start with lower gray matter and you're going to have pain. This is actual loss of gray matter during chronic pain. So the brain and how it responds, not necessarily the injury. So, you see many times people say, my MRI, it looks terrible. And then you see someone else whose MRI looks terrible too. This person has no pain, this person has terrible pain. It's what's happening with those MRI findings when they get to the brain that may be leading to their current symptoms. For patients with low back pain, just viewing a threatening image, so viewing an image in the scanner or just viewing the image in video of picking up something heavy induces pain. So all the patients with chronic back pain who saw this image of lifting something heavy felt uncomfortable. And 7 of 11 of them felt pain in this study, whereas no control subjects who had no chronic pain had any response to this particular image. The pain patients had increased activity in the brain in pain and emotion-related regions. So these regions will come up again and again, the insula, the cingulate cortex, the thalamus, the hippocampus, those areas where we process pain and where we process emotion and where we hold our memories of pain and what they mean. In irritable bowel syndrome, shifting to the visceral pain, it turns out that there's, and if we looked at migraine headache, we'd find very similar things. We see similar regions of the brain involved. So we see decreased gray matter in the insula, the prefrontal cortex, hippocampus, cingulate, amygdala. We see increased gray matter, which we also do in chronic back pain, in the somatosensory cortex. So the one area where there's actually an increase is where we feel pain. When we look at patients with irritable bowel syndrome, there is a way that we test visceral sensitivity by putting a balloon within the lumen of the gut and blowing that balloon up and sensing when they have pain. So in some patients with IBS, they have the same sensation as a healthy control. And in some patients with IBS, they're much more sensitive and they feel that balloon much earlier. So those are normosensitive and hypersensitive patients. So when you take this balloon and you place it in the patient without chronic pain, and you say, I'm going to blow up this balloon in a minute, but you don't change the balloon, this is what their brain does. It has a change in its prefrontal cortex, so it decreases a region of the medial prefrontal cortex, and a little bit of activity lights up in the anterior insula, which is where we put together our emotions, our cognitions, and our sensations of pain at a conscious level. And so that's what it looks like. In a normosensitive person with IBS, we don't see those changes in the prefrontal cortex, and we see that the insula, where we process our visceral pain, is blazing on both sides. We've not blown up a balloon. And this is compared to not expectation, a safe period. When we look at the hypersensitive, not only do they not disengage that prefrontal cortex region, they have even more of the insula, and they bring on the thalamus, which is basically where the incoming pain comes from. Basically, it looks like we've inflated the balloon, and we have not. We've just said that we will. So the way that the brain works in these patients with pain is to create the pain even before the pain occurs. So in summary of the changes that we see in brain structure and function in chronic pain, we see decreases in gray matter in regions associated with pain and affect, in the salience regions where we determine how important pain is and how we modulate pain. We see increases in gray matter in where we sense pain in the primary somatosensory cortex. We see exaggerated responses to the expectation, to even the thought of pain. And we see increased recruitment of arousal networks, the amygdala reward networks, in response to pain or thoughts about pain. We see altered function in prefrontal modulatory regions along with decreases in gray matter. So while many of us in this room probably come to the table saying, well, I know that these mind-body things are good for, they're going to be good for pain. I've seen it. I don't need any data. These things work. You know, our situation in this country is such that I can't prescribe yoga for my patients who have chronic pain and get that covered. I can't prescribe, I can rarely even prescribe CBT or hypnotherapy for irritable bowel syndrome and have that covered unless they have a comorbid condition like anxiety or depression, which will cover it. I can't send them to Tai Chi. I can't send them to meditation and have that covered. I can write them a prescription for Vicodin. I could do another colonoscopy and tell them that it's normal. I can do another CAT scan, probably make them more anxious and increase their risk of cancer by increased radiation. There are a lot of things that I can do, but I can't do some of these things that I think are useful. And so while I fall into the camp of believing that these are effective therapies, I think it's really important that we try to understand the mechanisms by which they're useful so that we can show that, you know, there is a biology behind this. And not only that, what I think we also need to do is by understanding the biology, we can start to manipulate some of the integrative therapies so that they're more effective for our patients. How am I doing on time?
Yeah, good.
I'm good.
Still do. Yeah.
Okay. So hypnosis is actually my favorite of these, and some people have it fall in the camp of complementary integrative therapies. Some say, well, that's traditional, that's just psychology. I think most people, and certainly when we talk to patients, most people are like, hypnosis, wow, I don't know about that. Hypnosis, one of the definitions being a state of consciousness with decreased voluntary action, responsive to suggestion or direction. And so it's a state of calm in the active mental state. So we calm down the active brain and allow it to be responsive to suggestion. Our goal being to change the way the brain is functioning so that we can intervene with some of these patterns that have developed over time in the brain that then can potentially allow the brain to heal and to re-engage those descending modulatory and prefrontal modulatory networks that are needed to control pain. So most studies have looked at the effects of acute hypnosis. Certainly what's more important is the effects of hypnosis over time. But in the acute studies, we know that the anterior cingulate cortex, its activity and connectivity is altered, and this is one of these regions that we've talked about. In the figure here, the anterior cingulate is one of the sort of way stations between our prefrontal cortex, which we're using to modulate pain, and our somatosensory cortex and insula, which are going to be sensing pain, and those descending pain modulatory areas. So by improving the integration of these regions, it's thought that hypnosis has some beneficial effects on both affect and pain. I like to think of it as magic, but there is a substrate behind it. So compared to biofeedback alone, hypnosis improves pain intensity, pain interference, with about 30% reduction of pain in patients with low back pain. You can see over time, pain intensity drops. At follow-up, it started to fade if there isn't any continued intervention. Pain interference, so how much pain is interfering with lifestyle, so a functional measure improves with hypnosis. And sleep quality improves, and that probably helps as well. In a PET study, so looking at brain metabolism in chronic low back pain, hypnotic suggestion activated cognitive sensory networks when in the alert state. So it got stuck in our cognitive thinking process when you give a positive suggestion when we're not in hypnosis. But under hypnosis, it activated, the same suggestion activates emotional networks. So we think that what we really need to do is activate those networks together. In IBS, it turns out as a clinical tool, hypnosis has been shown to be very effective. It utilizes deep relaxation, imagery, and positive suggestions for decreasing pain, for normalizing bowel function, for reducing anxiety, and regaining a sense of control. And when I describe this to my patients, they often think that I'm pretty nutty. But for those, any of you who do hypnosis or have undergone hypnosis, the scripts for IBS are very formalized and reproducibly studied. They have a very long induction, so it's really about bringing down that agitated nervous system and calming people. And there's a very short and very simple intervention targeted on the gut. Things like your intestines are becoming much less sensitive to pain as healthy, soothing waves of change spreads deep inside your body. So simple stuff. First time I read the scripts, I was really surprised by how little of it was actually gut specific. And really about the individual gaining control over these symptoms and taking over that control. Compared to usual care, so whatever medications the doctors were prescribing, dietary modulation, or supportive therapy, hypnotherapy improved symptoms much more in patients with IBS. And these studies done in the UK, where they're looking at people over time, were able to show in observational study, but not randomized, that those patients who came in with very high symptoms, so the total symptom score in IBS, we consider a 300 to be a moderately severe in terms of symptoms, and so the patients who ended up in these clinics were patients who had fairly severe symptoms. They had a significant drop, so we consider a 50-point drop in this scale clinically significant. So as you can see, they dropped far more than 50 points. They came down, and then they followed them over 5 years, and they saw in these patients a sustained benefit at follow-up. I don't have a single medicine for irritable bowel syndrome that I can give to someone for 2 months, stop it, and have them be better for 5 years. It just doesn't work that way. So this is a long-term benefit from a short-term treatment. How does hypnosis affect the brain in IBS? So this in another study looking at 17 women using standardized hypnosis over 10 sessions with an education group as an active control showed that both groups actually got better. The patients with hypnosis got much better. And if you remember those pictures I showed you before of the brain and its expectation, so these are the IBS patients before hypnotherapy with the expectation of pain. This is during visceral pain. This is when the balloon is distended. Looks the same, right? So a little bit extra stuff happens, but not a lot more. Really, expectation is the pain response of the brain, at least in these structures. There are other structures we're not showing. And then after hypnosis, if you have a recollection of what that healthy control looked like, we start seeing these deactivation in certain regions in the prefrontal cortex. We see shrinking of the activation in the insula. We go back to seeing really just a unilateral activation of the insula during expectation, and just a little bit more during the actual painful distension. And so we see a normalization of those abnormal brain activity after 10 sessions of hypnosis. We also saw that in the resting state, both hypnosis and education could normalize resting brain circuits. The posterior insula is our primary interoceptive cortex, so where pain from the gut initially goes, and how much that area was connected to sensory motor networks just at rest, this is not with a balloon in place, this is just a resting state. How active that was in connecting to sensory networks was highly correlated with their symptoms. And after successful treatment with hypnosis or education, there was an improvement in that posterior insula connectivity and an improvement in symptoms. So the brain changed. Now in cognitive behavioral therapy, we see very similar things. So CBT for chronic back pain is thought to reduce negative thinking, catastrophizing, CBT for any pain. That prediction error that we talked about earlier, where you have a sensation and take it to its worst possible case scenario, that is blunted with CBT, and a diversion of attention. So in CBT, relaxation, breath training, reducing the hyperresponsiveness of the nervous system, using guided imagery were the approaches taken in this study of chronic back pain. And the brain changes that they saw included increased gray matter volume in the prefrontal cortex, so one of the main regions that we saw to be decreased and diminished. And that degree to which the prefrontal cortex increased in volume correlated with the degree of catastrophizing that those patients had. So using a brain-based mechanism to interrupt that catastrophizing and actually reduce the amount of pain. In irritable bowel syndrome, there was a meta-analysis looking at this. There's been a fair amount of literature on CBT for IBS. It's very successful. It reduces symptoms by about 50%, with a number needed to treat of 2 to 4. Still, if you're not improving everyone, so it is a costly intervention. But if we see long-term effects, and we see additional effects on comorbid disorders such as anxiety and depression, I think we're making a true benefit. The central mechanisms are, again, thought to involve prefrontal inhibition, changing that prediction catastrophizing circuitry that goes off, decreasing activity of fear and anxiety circuits. When looking at the benefit of CBT and IBS, this study by Jeff Lackner, which we're looking at now in the brain using these same interventions, whether he used standard CBT or what he calls a minimal contact CBT, so only 3 in-person visits and the rest done at home, he sees real improvements in symptoms compared to a waitlist control. What about the other things that we do for IBS? And I think there isn't a study looking at this for chronic back pain, NSAIDs, and opiates, but if we look at all the drugs that we use for IBS, CBT has a responder rate. Jeff he made these slides, he's really positive. So at the best, 80%. Most of these have a 70 to 80% responder rate though in IBS compared to a waitlist control. And these would be rifaximin, recently FDA approved. So you have this is generous. It's really more like a 30% response rate. Placebo, Amitiza, another drug for IBS, where we have a 20 to 30% response rate in the placebo used in that trial. So a mind-based therapy for a condition like IBS, and I would think also those studies haven't been done in chronic back pain, these work better than our drugs. What about meditation? So meditation is considerably more hip and popular right now than hypnosis or CBT, and it's one of the things that that actually drives people to use intervention. So I find it helpful as a way of motivating people to use meditation. I think 10 years ago when I suggested meditation to patients, I had a lot more pushback. I can't do that. Meditation's not accessible. That's just for like this special group of people who go up on the mountain, meditate. I think now people see this on every magazine. They see this on TV. They see their favorite stars, from David Lynch to Oprah to Deepak Chopra to Ellen, meditating. They think, oh, okay, well, maybe I can meditate too. The research in meditation has gone up tremendously in the last decade. But we still see some barriers to meditation. And I think the biggest one being people have difficulty, particularly people with chronic pain, being quiet and sitting with their thoughts. It can be physically painful, so the invasiveness of the pain, but I think psychologically also, it's a time where negative thoughts can come in. And so for patients to just go out and meditate can be quite hard. There's a very nice study that was done that looked at putting healthy people in a room with an electrical stimulator that caused a painful stimulus, so a shock device. They could press and cause a shock, and they had them press it, cause a shock. Ouch. They left them in a room for 15 minutes. Just do whatever you want. Well, we'll be back in 15 minutes. Just hang out. And would you push the button for like a painful shock? Like I would imagine that I wouldn't, but there were people who pushed that button 100 times. People push that button. They do not like to be left with their thoughts unguided in a room alone. They push the button. And so mindfulness-based stress reduction, which is what we've been studying at UCLA in irritable bowel syndrome, and which has been used in a number of different pain disorders, I think is a very easy way in for people. Easy is not probably the right word, but is a way in for people for those people who do have difficulty just sitting with themselves and their sensations, because it's quite organized. So MBSR has been around for quite a long time, developed by Jon Kabat-Zinn, using the ancient teachings of meditation, but sort of formulating them for those of us who may not be as comfortable with basic sitting meditation. It is very attractive for research because it's quite structured and reproducible. It involves both sitting, breathing, thinking about, so it involves a fair amount of cognitive work, as well as movement, some mild yoga. The basic concept being non-judgmental focus on the present moment to break that cycle of going to the next place or going to the last place and enhancing pain. So what is it good for? In a recent very large meta-analysis, when they looked only at those studies that had active control groups, it found that MBSR was good for anxiety, depression, and pain with moderate effect sizes. There's no evidence that meditation was better than any other intervention, so it didn't work better than antidepressants, which were the most common of the active controls, or non-steroidal anti-inflammatories, et cetera, for pain. But they're not looking at this in a holistic and long-term way, because I had a lot of people come to me like, oh, did you see that meta-analysis? See, it's no better. It's no better. Well, yeah, in a short-term situation, it may be no better than an antidepressant. But what about over the long term when you've just given someone a self-care skill that they're going to take home, and if they're lucky and hopefully trained appropriately, will potentially use for the rest of their lives, that may help their anxiety as well as their depression as well as their pain, maybe even help how they interact with the world, and general sense of well-being. So I'd say that despite the fact that they were no better than the other pharmaceutical active treatments, they're probably better. MBSR looks about the same as cognitive behavioral therapy in terms of its efficacy. In here, MBSR and cognitive behavioral therapy for chronic low back pain, both against usual care, show considerable benefits in disability for chronic low back pain, as well as pain bothersomeness. So both of them quite effective. MBSR is shown to be very effective for IBS. So in several studies, about 70% of patients receive a decrease in their irritable bowel symptom scores by that 50 points that we're looking for. And most of them show, and ours show the same, you get a benefit at the end of treatment, but when you look at them 3 months later, they're actually doing better than they were at the end of treatment. So what you're seeing is what we hope to be a gradual change in those parts of the brain that had become aberrant, and a healing of those abnormal circuits. And so that's what we're looking at now. In terms of what is happening with the specific aspects of mindfulness in our group, the facets of mindfulness that correlated best with improved symptoms were acting with awareness in the present moment and being able to describe what was happening in the present moment. So really being there and accurate as to what their sensations are at that moment and not going to another place. We also see in our early analysis of the brain changes in the brain microstructure, so looking at the white matter tracts in the region of salient circuitry, where it looks like there's improved connectivity in people after they've gone through this intervention. But what about placebo? So people really don't like the placebo effect. I like to call it a non-specific effect rather than a placebo effect, because the placebo effect is our body's natural ability to heal. It's not like a dirty word, you know, it's not like the bad treatment. If you have a placebo effect and it works, that is your body's natural ability to heal. And congratulations to that patient who has a big placebo response. In our area, people always give IBS a bad rap for having a good placebo response, 40 to 50%. I would say that's fantastic. So in this study of 80 IBS patients randomized to 3 weeks of placebo or no treatment, both treatments were given in a warm, supportive patient-practitioner relationship. Tony Lembo, who did his training here and used to be on faculty in the GI division, who's now in Boston, did this study and is one of the nicest people, was the warm and supportive practitioner in this study. And they used the same scales that we use for the other studies. And they said this, they said placebo pills, something like sugar pills, have been shown in rigorous clinical testing to produce significant mind-body healing processes. So that was their intervention. They gave some people nothing, and they gave some people an open-label placebo. And they looked at them at the end of 21 days. And in no treatment, yeah, people always get better because they got to talk to Tony Lembo, and he is really therapeutic, and he helped, right? So their overall symptoms, their IBS symptom severity, their adequate relief, their IBS-related quality of life all got better. But if they got the placebo, they got even better. So, so it doesn't have to be meditation. It doesn't have to be cognitive behavioral therapy or yoga. It could be a pill if you want. It really has to do with allowing that person to find the way that their body heals itself. What is the most effective way for this person with chronic pain, who may also have anxiety and may also have depression? What is the most effective way into that brain that allows it to heal itself? And if you're really lucky, it'll be placebo, because the doctor will give you a pill and you'll get better, and maybe you'll stay better. This was a short-term study. I don't know what they'd look like at 3 months. If you weren't that lucky person that has that tremendous placebo response, you may take a little bit more work. It may take some hypnosis, cognitive behavioral therapy, meditation, or yoga. The key points that I'd like to emphasize is that chronic pain, more than anything, is a disorder of the brain. That pharmacological therapy alone often fails because it's targeting different things. There will be no drug developed that targets the complex circuitry within the brain that causes chronic pain. And I would say also similar for some of the mental health disorders. Mind-body therapies are a way in to that complex structure to change brain structure and function, improve pain symptoms and quality of life. And our understanding of this process, I think, is very important for patients to understand. Changes occur in the brain. This will take time to heal, but we see it happen in our patients, not only in their symptoms, but also in their brains. So what's the future? Can we predict what treatment a patient will respond to? I wish I could talk to someone and know that I should do medicine for this one, cognitive behavioral therapy for this one, mindfulness for this one. Maybe we'll be able to get to that point. Should we be choosing our interventions by the disorder? Is mindfulness better for IBS, but CBT is better for back pain? Or should we just go with what the patient wants? Because maybe they know best, and if they want to do this therapy, that might be the best one, which means we need to have choices in our systems. And even more importantly, can we prevent this? If we know this is what happens, we know that potentially what kind of activities put us at risk for chronic pain, can we intervene? Can we take our kids? Can we say, you know what, we need to get you started doing this now, because why even develop chronic pain ever and go backwards? So I'll leave you with this quote: pain is inevitable, but suffering is not. We'll all have some pain. Hopefully we won't suffer. Thank you. And I'm happy to take any questions you have.